Hello students, today we will discuss about the anatomy of ischioanal fossa. Earlier this ischioanal fossa known as ischiorectal fossa, but you have to understand that we are talking about the space around the anal canal. And when we are using the word ischiorectal fossa, that means we are using the space around the rectum. And in this image you can see that this is your area of pelvic diaphragm. And whenever you are talking about the rectum, it is above the pelvic diaphragm. So if we'll have the ischiorectal fossa, that means I am in this space. But we are not using the area above the diaphragm. We are talking below the pelvic diaphragm. So that is around this anal canal. That's why we are using the word ischioanal fossa. Clear? So what is this ischioanal fossa? So it is a gutter-shaped space. Gutter-shaped space means you have the potential spaces on both the side of your anal canal in anal triangle, and these areas are known as ischioanal fossa. These are inverted wedge-shaped gutter which occurs between the levator muscle and adjacent pelvic wall as the two structure diverge inferiorly. Now what does it mean? That when you will see this image, you are able to understand that this is your pelvic diaphragm. Now when you will go down, this is your wall on the inner side of hip bone, which is known as lateral pelvic wall. And on this lateral pelvic wall, you are having a muscle is known as obturator internus. So when you will go down, you will find that there is a diversion. This is a vertical straight pelvic wall, and this is your pelvic diaphragm. And in between these two, you are having these spaces, and these are known as ischioanal fossa. These spaces consist of the fat. The ischioanal fossa allow movement of the pelvic diaphragm and expansion of the anal canal at the time of defecation. So what is the use of these fat-filled spaces? So the only answer is that it is helpful in modify the dimension of the anal canal at the time of defecation. The ischioanal fossa is a wedge-shaped space. So when you are talking about the shape, it is a wedge-shaped. And the base of the fossa is formed by the skin around the perianal region, and it is directed downward towards the surface. So what is the base? Now this is the base of your fossa. Now on both the side you are having the skin around the anal canal, which is known as perianal skin, and this perianal skin is going to form the base of ischioanal fossa. The apex, when you will talk about the apex, it is directed upward and it corresponds to the line where the levator muscle and the obturator fascia are meeting. So here where you will have these two areas, so this is your origin of levator and this is obturator internus. So this point of the meeting area on the upper part is known as apex. So this is the base of the wedge, and this is the apex of ischioanal fossa. Now what is the dimension of the fossa? Now when we will talk about the length, width and depth. So what is depth? Depth will mark the depth from the superficial area. So this is your skin which is going to form your base. Now from here, if you will take a measurement, so this is known as depth. So this depth, which is vertically, is around 5 to 6 centimeter. Now when you will have side to side width, now this is around 2.5 centimeter, and when you will have anteroposterior length, you will have roughly around 5 centimeter. Now what are the boundaries of the ischioanal fossa? You have seen the base, you have seen the apex. Apart from that, it is having the lateral boundary, medial boundary, anterior and posterior boundaries. And the important thing is that these boundaries either made up of the muscles or the fascia. So you will find the lateral boundaries, you will find the medial boundaries, you will find the anterior and posterior boundary. So let's see first what is the lateral wall. Now when you are talking about the placement of the lateral wall, it is nothing but it is vertically oriented inner aspect of both the side of hip bones or more particularly both the side of ischial tuberosity. So it is formed by the fascia which is covering on the surfaces of obturator internus muscle and the medial surface of ischial tuberosity. And this obturator fascia splits in this part of ischioanal fossa to form pudendal canal. So pudendal canal become the content of lateral wall. Now here in this lateral wall, this is your inner side of your obturator foramen, which is covered by the obturator internus muscle, and this obturator internus is further covered by the fascia, and this is known as obturator fascia. Now this is the medial surface or inner side of ischial tuberosity. Now at one point you will find that there is a presence of a canal, and this canal is known as pudendal canal. So when you are talking about the lateral wall, you have to write down that the lateral wall is vertical and it is formed by the obturator internus, which is covered by the fascia, pudendal canal and inner surface of ischial tuberosity. Now what about the medial wall? Now medial wall is having the two part. In upper part, it is formed by the inferior fascia of levator ani or the pelvic diaphragm, and below it is formed by the external anal sphincter. So this is something is important, that in upper part, when you will see in this image, this is your medial wall, and this medial wall is having two components. Now this part is formed by the inferior fascia which is covering the pelvic diaphragm, and this part is formed by this external sphincter of anal canal. Now when you will see the medial wall, it is joining here with the lateral wall. So this is your lateral wall, and this point of the joining of medial and lateral wall is known as apex of ischioanal fossa. Now what is anterior boundary and what is posterior boundary? Now anteriorly, the fossa is limited by the posterior border of urogenital diaphragm and perineal membrane. Now this is something is important, that when we are seeing from the posterior side, now this is, you can see the sacrum, and when you are looking from posterior side into the pelvis below the pelvic diaphragm, we are talking about the space which is going to present in these two areas, and these are the ischioanal fossa. Now when you will see anterior extension, you are able to appreciate that this is the posterior free margin of perineal membrane. Clear? But there are two terms. One is anterior border, another is anterior recess. Now my dear students, the recess will be this gap. Now this gap is the gap above the perineal membrane or urogenital diaphragm. So that gap above the urogenital diaphragm is the recess. But the posterior margin of perineal membrane, or you can say urogenital triangle or urogenital diaphragm, is anterior boundary. The extension above or behind this anterior margin is known as recess. In the same way, when you will have the posterior border or the limit of the fossa, it is lower border of gluteus maximus and sacrotuberous ligament. So here you can see that this is the sacrotuberous ligament, and this is your demarcation line of posterior part of ischioanal fossa. But my dear friends, you have to understand that this fossa will also extend through this lesser sciatic foramen. So this extension is beyond this posterior margin. So again it is known as recess. So there are two terms. What is recess? Recess is a extension beyond the limits. And what is boundary? Boundary means at what point the major part of the fossa is present. Clear? Now here in this video clip, if you will see the relation of the fossa with the levator ani, pudendal canal and obturator fascia, you first find out that this is the posterior view of the pelvis, and you can see that this yellow color is your pelvic diaphragm. Now on the both side, it is covered by this white color area, and this white color area is actually your fascia of obturator internus. And you can see this obturator internus which is coming out, and this tendon is coming out through the lesser sciatic foramen. And also you can appreciate that this is greater sciatic foramen, and through this foramen this nerve is coming out, and this nerve is again re-entering here, and this is your pudendal nerve. So first, before reading the ischioanal fossa, you should have the basic orientation about these structure, that what is the relation between the lateral and medial wall. Now, if you will see the further relations in this clip, what you are able to understand, that if you will remove the pelvic diaphragm, you can see that both the side you can now more easily appreciate the lateral wall. Now, from this you are having, these are what? Your pudendal canal. Now, in the pudendal canal, this nerve is running and this nerve is your pudendal nerve. So, this is the important thing, that pudendal nerve lies into the lateral wall of your ischioanal fossa, and medially it is covered by the inferior surface of pelvic diaphragm and your external sphincter of anal canal. Now, what are the recesses, if somebody will ask? So, first is anterior recess. I just told you that the ischioanal fossa continue anteriorly with a recess that project into the urogenital triangle superior to the deep perineal pouch, or it is the another name of your urogenital diaphragm, and the apex is closed and it goes towards the pubic bone. So, it approaches the pubis, and anterior recess is normally filled with the fat. Now, again, try to understand what is anterior recess. So, when you will see the posterior margin of this area, now this is the posterior margin of your urogenital diaphragm. Now, here still you can see that there is a gap present anteriorly on both the side of your this urogenital triangle. Now, the recess is this and the fossa is this. So, this fossa is extending anteriorly beyond this posterior border of urogenital triangle, and I just told you the recess is the limit extension beyond the limit. So, this is going anteriorly and it will touch the posterior side of the pubic bone. Now, what is posterior recess? I just told you that posterior recess continue with the lesser sciatic foramen located deep to the sacrotuberous ligament and gluteus maximus. So, again, the important concept to understand that this sacrotuberous ligament is the posterior limit of the posterior extension of the fossa, but the fossa may extend through this lesser sciatic foramen in this area, which is covered by the gluteus maximus, and this posterior extension of the fossa is known as posterior recess. What is horseshoe recess? Sometimes both the side of the fossa are connected to each other behind the anal canal and they will make a U-shaped recess, is known as horseshoe shaped recess. Now, in this image you can see that this is the posterior part of the perineum where you have the buttock. So, if you will remove the skin of the buttock region, you will find the gluteus maximus muscle on both the side. Now, I already told you that deep to the gluteus maximus, you will have the posterior extension of the ischioanal fossa. So, where is the anal canal? Now, this is the anal canal, and in these areas you are having the ischioanal fossa. So, if you will remove the gluteus maximus, now you can see that this is your ischioanal fossa, which is coming out from this lesser sciatic foramen, and it was earlier covered by the gluteus maximus. Now, when you will see from the below, what you are able to understand, that in the lower part you will find that this is the fossa which is giving the anterior extension, and that anterior extension is going above your urogenital diaphragm, and that anterior extension above this urogenital diaphragm is approaching to the posterior part of pubic bone. Clear? So, when you are having the recesses, you have to keep this thing in mind, that this is your area of ischioanal fossa, which is posteriorly limited by the sacrotuberous ligament, but it may extend outside through the lesser sciatic foramen, and it is covered by the gluteus maximus. And in the same way anteriorly, this fossa may go anteriorly above the urogenital diaphragm up to the posterior surface of the pubis. So, this is anterior recess and these are the posterior recess. Now, what are the further division of the spaces of the fossa? The arrangement of the fascia in this region form the two further spaces, perianal and ischioanal. Now, perianal space is a subcutaneous space which lies just below the skin, and this ischioanal space is a deep space, or it is known as ischioanal fossa proper. The perianal fascia which form the septum between these two spaces. Now, again you have to first understand this image, that when you are talking about the division of the ischioanal fossa, you are having a horizontally placed fascia. Now, this horizontally placed fascia is known as perianal fascia, and this perianal fascia divides the ischioanal canal, ischioanal fossa in two parts. Now, this upper fossa is known as ischioanal fossa, and this lower fossa up to the skin is known as perianal fossa. So, perianal fossa is a small, ischioanal fossa or the fossa proper is a big fossa. So, what is the line of demarcation? Perianal fascia. The septum passes laterally from the lower end of the longitudinal coat of the anal canal to the pudendal canal. So, that you can see it is passing horizontally. Now, it separates the shallow subcutaneous perianal space from the deep ischioanal space. Now, perianal space is a small, shallow, it lies between the skin below and perianal fascia. So, you can see that this is a shallow space, it lies between the skin and the perianal fascia. But the important thing that when you are talking about the differentiation between the perianal and ischioanal space, you have to keep this thing in mind, that the perianal space is having tightly arranged fat loculi, and they are actually having a complete septas. What is the important thing is that in this perianal space, you are having the complete septas, plus the fat which is present here is tightly packed. And because of this reason, the infection in this space are highly painful because of the tightly packed loculi in the perianal space. On the other hand, if you will see the ischioanal space is having loosely arranged fat lobules which are large in size, and the septas are incomplete. Now, because of this difference, the infection into the ischioanal space are not that much painful, or they are least painful because they don't have any tension. So, this is the question for your exam, why the infection in perianal space are painful, not in the ischioanal space. So, you have to keep this thing in mind, that ischioanal space is having loose arrangement of the fat, while the perianal space is having tight arrangement of the fat. The ischioanal space is further divided into the two parts by the lunate fascia. Now, this is again the important thing to understand, that what is lunate fascia? Lunate fascia is a half moon shaped structure, and this lunate fascia is going to divide this ischioanal space into the two parts. So, the line that lies deep into the fossa is known as lunate fascia. Now, see, in some books you don't have this description about the lunate fascia, but if you are having this concept of the lunate fascia, you have to keep this thing in mind, that when you will see the ischioanal fossa, the deepest fascia is lunate fascia. If you are using the term lunate fascia, it is the deepest fascia of ischioanal fossa. It is in an arch shape, and laterally it covers the obturator fascia. It merges with the periosteum of the ischium on the lateral wall. So, it covers the medial side of your obturator fascia, and it ultimately merges with the periosteum, and also it merges with the fascia around pudendal canal. But when you will see medially, the fascia will go and merge with the fascia around the anal canal, and it merges with this area where you have the orientation of perianal fascia. So, ultimately you are having a perianal fascia which is here, then you will have the obturator fascia which is here, then you will have anal fascia which is here, and you have the lunate fascia which is here. So lunate fascia concept is not there in every book, but if you are using the word lunate fascia, you have to keep this thing in mind that it is a deepest fascia of ischioanal fossa, and it is an arch-shaped fascia which medially merge with the anal fascia, and laterally it will merge with the obturator fascia and ultimately with the periosteum on inner side of ischial tuberosity. Now this summit or the tip of this lunate fascia is known as tegmentum. Now what are the contents of ischioanal fossa? Now when we will talk about the contents, you are having the fat which is present throughout. Apart from that, we are having the pudendal canal. Pudendal canal is a very important content on the lateral wall. The pudendal canal give rise to the nerves which are known as inferior rectal nerve and vessels. So these inferior rectal nerve and vessels cross the fossa from lateral to medial side. Then we have the posterior scrotal nerves and vessels which are going to supply the posterior scrotal skin. Then you have the perineal branch of the fourth sacral nerve. You have perforating cutaneous branch of the S2, S3 nerves in the posterior part. So when we are talking about the inferior rectal nerve and vessels, you have this question that which structure crosses the fossa. So which structure crosses the fossa means that this is your pudendal canal where you have the entry of the two structure, pudendal nerve and the internal pudendal artery. When they are passing through the canal, they are giving two branches. One is the artery and one is the nerve, and they are approaching the external anal sphincters by passing through the fat which is present into your ischioanal fossa. Then what is about the posterior scrotal nerve and vessels? Now you have to understand that this pudendal nerve, when passed through this pudendal canal and when it approaches the anterior end of the pudendal canal, at this point it is going to divide in the terminal branches, and these are the posterior scrotal nerves, and these posterior scrotal nerves are not crossing the ischioanal fossa, but they are present along the posterior margin of perineal membrane, or you can say the anterior part of ischioanal fossa. So there is a confusion. What is the confusion? The nerve name is posterior scrotal nerve, but what is the part of the fossa? Anterior part of the fossa. Clear? Then what is the clinical use of ischioanal fossa? The first use is the fat. We know that fat provides cushion-like support to the rectum and anal canal, but in case of the loss of the fat in debilitating diseases, what will happen? That the rectum will prolapse downward in the lack of the support or due to the creation of the large spaces, and that is known as rectal prolapse. Second thing is that the ischioanal fossa sometimes become the site of internal hernia. Why? Because there is a hiatus of swell is present. Now what is hiatus of swell? When you will have the abnormal origin of your levator. Generally you can see that levator is arising from a tendinous arch on inner side of obturator fascia. But suppose rather than taking origin, there is a gap is present. This gap, if the gap is present here and the muscle will arise from this point, what will happen? This peritoneum will herniate through this gap into the ischioanal fossa. So this hiatus which is present here due to the abnormal origin of your levator is known as hiatus of swell, and through this hiatus sometimes the intestinal loops and the peritoneum herniate into this fatty area, and that is known as internal hernia of ischioanal fossa. Apart from that, you have the abscess in this area. So the abscess in the ischioanal fossa occurs because of the hard feces injury. Now when there is a hard feces injury, the mucosa of the anus and an infection can develop in the anal gland. So whenever there is a persistent hard stool passed by the person, what will happen? The anal gland around that part of the anal canal will get infected. So because of that infection, what will happen? Ultimately, the abscess will form in those glands. So first is there is a hard stool. Because of the persistent hard stool, there is an injury of the mucosa. The mucosal injury will lead to the infection of the glands, and that gland infection will convert into the abscess. So the abscess once become, it will start to enlarge, and the enlarge and spread of the abscess along one of the several plane in the perianal and perirectal spaces. So this is the important thing to understand, that the abscess can be formed in anywhere in the anal canal, and these abscesses are become the cause of fistula. Now what is fistula? Fistula is a tract which is hollow and it is an infected tunnel, and this tunnel is having an inner opening and outer opening. So the inner opening is always inside the anal canal and external opening is in the perianal skin. So here you can see that different tracts are there. So one opening is, it can be above the your pelvic diaphragm in rectum, one opening is high in the anal canal, one opening is low in the anal canal. So one opening is inside. External opening is on the perianal skin, which can be in any place. And these are what? These are actually the complications of abscesses. So what is the abscess? Abscess is infected anal gland, which actually the reason because of the injuries of the mucosa due to persistent hard stools. Any surgical intervention in the fossa, you should always place transverse incisions. Why transverse incisions? Because you know that the vessels and the nerves are present in the fossa. So if I will put the vertical incision in the fossa, I will cut these nerves and arteries. So to avoid any chance of to damage, we always prefer the horizontal incisions, so that if we'll make a cut on the fossa, we can prevent the injuries of horizontally placed nerves and vessels. So always avoid the vertical incisions in case of perianal abscesses. So now at the end of this class, you will have the idea about the orientation of ischioanal fossa, what are the different boundaries of the ischioanal fossa, what is lunate fascia, what is the difference between the ischioanal space and the perianal space, and lastly, what is ischioanal abscess and fistula. So this is all for the session. Thank you.